My name is Pedrini. I am a vascular surgeon and I designed the spinal study. I was the principal investigator and responsible of the core lab evaluation of all the patients' imaging. We designed this multicenter randomized controlled trial with the central randomization and the core lab evaluation of angiography with the aim to compare the clinical efficacy and the safety of spinal cord stimulation that we call SCS versus iloprost in patients with severe unrevascularizable ischemia of the lower limbs due to atherosclerotic disease, and to identify predictive parameters for a positive outcome of SCS. The sample was subdivided into two treatment arms, SCS and iloprost, and into two subgroups, pain and ulcer or gangrene. After 15 days, clinical efficacy was evaluated, defining as responders patients who had reduced pain and an ulcer increase. Responders continued follow-up in their arm, while non-responders could change arm or decline their participation. Primary endpoint was 1-year limb salvage rate. Principal secondary endpoint were survival rate, pain relief, and predictive criteria regarding SCS outcomes. The trial was stopped at 35% of the expected sample due to a low accrual rate. 52%, 55 legs, entered the study. At 15 days, we recorded 74% of responders in SCS arm and only 26% in iloprost arm. Pain reduction was obtained in 87% of SCS and 35% of iloprost arm. 9 non-responders iloprost patients underwent SCS implantation, so-called iloprost plus SCS arm. After 1 year, limb salvage were 66% in SCS and 57% in iloprost, and 100% in patients who had iloprost plus SCS. Survival rates were 73% in SCS, about 94% in iloprost and 89% in iloprost plus SCS, confirming other studies which showed a trend towards better amputation for salvage in the SCS group. The small number of recruited patients prevented from reaching the statistical significance. Spinal study is the first randomized controlled trial comparing SCS versus iloprost. Moreover, although incomplete, it evaluated a sample greater than those studied in 3 out of 5 available randomized controlled trials on spinal cord stimulation. However, the small sample reduced the statistical power of this study, with possible type 2 errors. SCS was associated with quick and better answer to pain, better tolerability, better early results than iloprost, but without 1 year significant limb salvage rate improvement. Iloprost improved 1 year survival in spite of adverse events and, following these results, perhaps should be used first. In conclusion, the results of this trial suggest that prostanoids and SCS are not alternative treatment. SCS can be considered the complementary and consecutive treatment for patients no more treatable with open or endovascular revascularization, and an alternative treatment only in a patient with contraindication to prostanoids. The association of iloprost and SCS seems to produce a synergic activity even in patients who have an effective prostanoid treatment, and seems to increase limb salvage, in particular in patients with very low baseline TCPO2.